Good evening, everybody, and welcome to the Royal Society of Medicine for the Stevens Lecture. I'm so pleased that we're able to actually deliver this lecture from our building, which we opened today. We're very excited about that, and I would encourage all viewers, all listeners to come and join in at the RSM over the next few weeks, and let's repopulate our building and get things going again. So the Stevens Lecture was set up by Arthur Edwin Stevens, CBE, who was a Welsh inventor and designed the world's first wearable electronic hearing aid. He was a philanthropist, and he donated a lot of money to the Royal Society of Medicine, also to Jesus College, Oxford. Now tonight, I'm pleased to introduce to you Ben Challacombe, who is an exceptional urologist. I've been working with Ben for approximately 20 years now. We sent him to Australia to learn how to be a really excellent robotic surgeon, working in Melbourne with Tony Costello, another famous robotic surgeon. And Ben this evening is going to tell you a bit, not just about urological robots, but robots in the broadest way, and he'll be looking to the future as well. So Ben, over to you, and thank you very much.
Roger, thank you very much for your kind invitation. It's a huge honour to give this lecture, particularly looking at who has given it in the past. It's particularly an honour tonight to be able to present in front of Lord Stevens and the Stevens family members, and to be back in the building. So, my name is Ben Challacombe. I work at Guy's, but tonight's not really about my institution. It's not really about my subject of urology. It's really about robotics in general. So first, a warning. For those of you out there, there are some clinical videos. There are some images. There is some blood, and there is a lot of robotics. There are some recognizable patients who I have worked with and looked after, but only those who've given their explicit consent. So there is a mixture of knowledge in the audience tonight. So I thought I would start by telling you why robotics. What is this? Why do we do it? So this is an operation on a kidney. This is not robotic surgery. This is laparoscopic surgery. And there's a lot of laparoscopic surgery. 15 million cases every year worldwide. 10 million operations each year in the UK in total, and of which a high proportion are laparoscopic. But this is me a few years ago, and I've made it bleed. And this is a difficult situation. This is a main blood vessel. This is the inferior vena cava, and there's a small branch being removed from it. And I'm trying to use straight stick laparoscopic instruments, chopsticks as some of us would call them, to try and repair this. My hands are juddery, they're moving about. I can't really tie a knot very easily because I haven't really got the ergonomic dexterity to do that. And luckily, we can sort it out, couple it together, and carry on. Now, what happens in robotics? Well, in robotics, a similar injury could occur. This is a partial nephrectomy on a single kidney in a young lady of 40. For a kidney tumour, and a branch of the renal artery, the kidney artery, is bled. And what do? Well, rather than just cobbling it together, I can use the dexterity of a multi-degrees of freedom instrument with a suture, a stitch that is effectively the width of a hair, to repair this, rather than chopping the artery, compressing it, or converting to open surgery. And that is the sort of thing that makes the big difference if you have this available. So what is it about? If you have an instrument in laparoscopic surgery, it can go into the body, it can go left and right and up and down, it can twist, it can perhaps grab something or cut something. And the difference in robotics is that that instrument has a wrist, and that wrist completely changes how you can do the surgery. Instead of struggling against the boundaries of what you're trying to achieve with suturing and stitching and dissecting. You've suddenly got your own hands, in a way, inside the patient. And I'll show you what I mean by that. So robotics is also a conceptual difference for surgery. I could do an operation and not touch the patient at all. I could do an operation and not even be in the same room as the patient, or the same town, or the same country. In fact, robotics came about from people thinking about doing operations in space. So this is an overview of what robotic surgery might look like. The surgeon away from the patient. So tonight I'd like to tell you and speak about what robotic surgery is, what the robots are and where they are, how they've emerged. What are we doing in the UK? Because some of you think that this is far-fetched. This is very well established. This has been going on since 2001 in the UK. How we train people, and particularly pertinent during COVID times. What other robotic systems other than the main one are emerging? What adjunctive technologies are coming along to make us even better at this and to give us other skills, other vision, other tactile feedback? And what I think may be, or may not be, the future of robotic surgery. So it's really at the moment about this. This is a Vinci Xi robot. This is your iPhone 12 of robotics. This comes with 1 or 2 seats. It can swing around. It has 4 arms. It's got HD vision. And it really allows you vision, precision, and control. So you put your head inside this viewfinder. You use the little wrists that go inside the patient, and you don't get tired. Your back doesn't hurt. You could do 3 cases in a day. You could do 4 cases in a day. In America, some people do 6 cases in a day staggered. So this is the generation going from the basic on the left to the middle one to the current one, the XI on the right, the SI, and the standard Da Vinci. So you've got 4 arms, you've got fingertip control, you've got that extra degree of articulation. I can have a couple of cups of coffee, I'm not going to have any tremor. Very different to laparoscopy, where the more tired you get, the more tremor you have, the more you concentrate, the worse it gets. This doesn't happen. And so you can scale the motion. I can move 5 centimeters outside the body with my hands, and it can be set to move 5 millimeters or 1 millimeter inside the patient. And the 3D view, whenever people visit me in theatre and they look at the screen, they don't really get it until they sit down and put their head in the console. And I think all of us who do robotic surgery, feel that is the key thing. It's when you sit down and you look. And there's the magnification. So what do we do in the UK? So this is a heat map, if you want, of the robotic areas in the UK on the top right. At the moment, 85% odd is urology. The biggest next group is gynecology, and then colorectal surgery and other general surgery. That's just the UK. And how has that evolved? Because that isn't really what it's like in the rest of the world. Well, we'll come on to that. But that's because we have an operation which really lent itself to doing robotic surgery. And why me? What credentials have I got to tell you about this? There are plenty of people who have done perhaps more robotic surgery than me. I suppose it's a love affair with robotics that started in 2003 when I was allowed to assist. And here I am in Australia. Professor Kirby kindly sent me with a grant from the Urology Foundation. I did a degree in robotics, went to Melbourne, came back, and at roughly 5 a week for 11 years, you can do the maths, done about 2,500 cases, mixture of prostates and kidneys. And I got a job title that wasn't really a job title at all when it started, which was being the clinical lead for robotics. We've got Professor Das Gupta as our academic lead. I was the clinical lead. Why do you need a lead for one robot? Well, you don't. But if you start talking about 4, 5, 6 robots, multi-specialty, multi-site use, working weekends, you need to know that the people you've got in place are the right people and select them well. And we train and we teach and we go around the country and teach. And they've even got me to wear an Australian hat in that one. So a little bit on the history of robotics. This is John Wickham. He was a supervisor for my thesis, and he actually had a true robot, because this isn't really a robot. It just does what we tell it to. It has no autonomy. It has no brain. It can't think. It can't move on its own. If I take my head out, it stops. Well, John Wickham actually designed a robot to do a TURP, which is our commonest operation in urology, removing the middle of the prostate. And this was from Tomorrow's World. You remember that program in the late 80s? And this was actually an autonomous robot with something with the capacity of about a ZX Spectrum. They set this up, and it would literally chop out the middle of the prostate. I mean, this is less memory capacity than storing one iPhone image. It's staggering. But of course, it wasn't exactly the full deal, and it was slightly dangerous at the time, and I don't think you would get that through the ethics anymore. So this is where Intuitive came in. They wanted to make robots for NASA. They wanted to make robots for the military in remote theatres of war. And they started the robotic system in '96. They got the Da Vinci first prototype in '99, FDA approval, which is like a sort of CE mark in the States, in 2000. And in 2000, they'd sold 18 systems. And here it is. It does look like something that a science geek has made in their garage and are giving a go to. And we go from that to the 4th generation that we use today. And they're not doing badly. They did 1.2 million procedures last year. They stuck in almost 1,000 systems in COVID, in the whole pandemic. They've now got 6,000 systems. Everyone writes about robotics. And they've done 8.5 million procedures. So that on the right there is a good graph of why I'm in surgery and not in finance. This is the share price of IntuitiveSurgical over the last 10 years. And my father-in-law, who's watching tonight, I said to him in his garden 15 years ago, you should get some shares in this, $5 a share then. $800 a share now. Well, Keith, if you'd have bought 10,000 shares at that point, or £10,000 worth of shares, we'd be sitting on 1.6 million now, because this company has gone from strength to strength, because it had no competitor. Where are they in the UK? Well, we've got 115 robots, 115 surgical robots in use in the UK. That is pretty much every area of the UK and Ireland has got a robot. 65 centres, many like us have more than one, and the variety of the SIX and XI robots. And as I said, in the world, it's not just urology. Urology is green. But actually, general surgery is the highest proportion. And interestingly, in this country, general surgeons haven't really been into robotics. They are now, and they're getting there. And gynecologists were not really into robotics, but they're even further ahead. And why is that? Well, we run a wonderful public healthcare system. This is an expensive technology. They didn't have the need and the use in the same way that we did with a delicate radical prostatectomy operation, perhaps. But I can tell you, at the moment, most of the systems being bought in the UK are being bought not for urology, so they're going to catch up quick. What do we do in the UK? Well, we do pretty much every prostatectomy is now done robotically, give or take about 10%. So that boat has sailed. All of the prostate removals for cancer in this country effectively, other than a few people who are still hanging on doing laparoscopy and open surgery, are done robotically. Partial removal of a kidney is the majority. Now that's not going to go to everything, because some cases are so complex they will require open surgery, as with cystectomy. Some cases will just not be suitable. So that's about as far as it's going to go in urology. So if you're going to sell a new robot, there's not much point selling it to a urologist, because we've got as much as we need to do at the moment. Where you want to be selling it is for people doing hysterectomy, doing colon cancer, rectal cancer, and taking out lung tumours, because they have got a huge area for growth, and they are a real area that the robot can excel in. What do we do at Guy's and Thomas's? Well, just quickly, we had a robot in 2003. We got a new one, then we got a second one in 2015, a third one 2 years ago, and we are looking at buying numbers 4, 5, and 6 fairly quickly at the moment, because everybody's very much keen on expansion, and some of that will be linked to things like COVID recovery. It's a delight to give a talk that isn't all about COVID, so I was planning not to speak too much about COVID tonight, as I think every aspect of COVID has already been covered by the president of the RSM over the last amazing series of lectures. But we'll have a little focus on robotic prostatectomy. So this is for men who have been diagnosed with prostate cancer that is contained within the prostate, that hasn't escaped, that's not in the lymph nodes. And this is a view of the prostate. Down is the bladder, up is the prostate. and the robot arm is coming in and dividing between the prostate and the bladder, the first sort of true cut of the procedure. And what I want to show you is with the 4 arms, you get this sort of field of vision where right in front of you, your arms work, underneath you, the assistant works. And we're going through the back of the bladder now, so that's completely detached, and lifting up the sperm tubes. So that is the seminal vesicles and the vasa, as in vasectomy. And these areas are sort of clipped off with little clips. This happens 9,000 times a year in the UK. It's happened to some fairly well-known people over the years. And what the robot does is it allows you to get views that were previously not really possible. You can look right underneath the prostate, almost as if your head is underneath the back of the prostate. You can determine exactly what little surgical plane, the body's tissues will come in different planes, and like an onion, you can peel off different layers. Well, here are the layers being peeled off in order to spare the nerves. And this is why the robot is so good for the prostate, is that these nerves are key for a man's potency, for erections after the surgery. And if you don't spare them well, then the erections don't come back. So the art of this is to remove the prostate cancer, but to preserve, if you can, the nerves. And through that, and linked to that, is the continence mechanism. By staying close to the prostate, one can also try and preserve the sphincter valve that keeps men dry. So there, you see, rather than operating down a very small, sort of a deep, dark hole in open surgery, small as in unable for us to really see, which is how I remember it, learning from people, you get to a perfect view that we can teach people and that we can go on, and I'll just move that a little bit. We can actually start doing the suturing. So for me, it's the nerve sparing and the stitching. And this is sort of stitching and with a dissolvable thread, the whole thing back together. And you can do angles that you just cannot replicate with laparoscopic surgery. Those angles coming straight towards yourself, left hand, forehand, left hand, backhand, right hand, backhand. I'm left-handed, but most people watching the operation wouldn't actually be able to tell what hand I was dominant in, because you don't have to think about it. You're just using your hands in front of you, and the robot is taking out the tremor and that sort of slight trepidation you have about doing something with your non-dominant hand. Anyway, enough of prostates. Let's move on to some kidneys. So, having got prostate sorted by about 2010 and really expanding this area, people started looking at whether it would be possible to look at taking out part of the kidney with the robot. And this is a rather large tumour at the bottom of a kidney. And it's the sort of tumour that you probably wouldn't usually do a partial nephrectomy for. And why can we do it? Because we've got good scans, we've got good experience, and we've got amazing robotic assistance. And this is the tumour at the bottom of the kidney, just where the metal instrument at the bottom is. And you can get right inside the kidney. So you can see from the CT there, this tumour is about half as big as the kidney. And we use those ultrasounds that you can see at the bottom. They're part of the sort of adjuncts we have for robotics. They can scan the kidney. They can tell me how deep the tumour is, where the blood vessels are, where the collecting area of the kidney is. And the idea is, and we haven't actually put any clamps on the kidney at this point, is to actually get the tumour out in a short period of time. And that period of time has to be less than 20 minutes. Because like having a rubber band on your finger, if you keep it on too long, the finger goes black. And if you keep it on the kidney too long, the kidney doesn't work again. So this is the tumour being removed. And again, like all surgeons, I've shown you a nice one. I could show you other ones that aren't as nice, but you'll get the idea, which is that you can remove the tumour, preserve the kidney, and hopefully do the whole thing in 20 minutes so that the kidney function comes back. Well, when is that really important? Not so important if you've got 2 healthy functioning kidneys. But how about if you've got only 1 kidney? Well, another adjunctive technology we use with robotics is something called ICG. Now, this is a dye. It's a dye that flows down an artery. And if you have 2 arteries and you only clip 1 artery, you can see where the dye goes to in the kidney. And the tumour's at the top with a little bit of fat on the top of it. And I've clamped 1 artery, and all of the kidney's gone green other than the part with the tumour in. Good news. So we can then remove the kidney tumour with a little bit of kidney and preserve the blood supply to the whole of the rest of the kidney. So in this patient with one kidney, this is a fairly high-stakes operation, because if you make a big hole in a single kidney and you've got to get it back together in 20 minutes and turn the blood back on, you want to know as much as you can about the blood supply to that kidney. What you don't know about is the blood supply to the deep part of the kidney, because you can only see the surface. So this is called ICG, and this allows you to do what's called a partial or a segmental clamp. I'm sorry, this is about as bloody as it gets. It's not too yucky. And there we are, putting the thing back together. And I suppose an interesting trial would be to put a blood pressure cuff and a pulse oximeter on me during this time, because this is a stressful 20 minutes and therefore quite tricky to teach. So the human factors of this kind of surgery are also themselves quite interesting. So there's some examples of the things that we might do. So what about UK robotic urology? We've done prostates, we do kidneys, and we can take out the whole bladder. We can also do a whole range of other things, which is kidneys that aren't draining well, kidney tumours in the ureter or in the middle of the kidney. We can take out the whole kidney, and we can take out the whole kidney that's gone into another organ. We can also do an adrenalectomy, take out lymph nodes, and other things. So my principles of robotics here are, I suppose, sort of shown by 4 slides of 2 scans and 2 patients. This is Rachel in the top left. She was diagnosed with a large kidney tumour in the second trimester of pregnancy last year in COVID, and we biopsied it and it was a tumour, and we made a decision that she was going to have her baby, and then we would do robotic surgery for her the week afterwards. And we took out a large tumour in her kidney, and she was in for less than 24 hours and back breastfeeding the next morning, walked out of hospital. That's not normally possible with this kind of surgery. She's pretty motivated. Top right is somebody with metastatic disease who's been on special new chemotherapy, immunotherapy drugs, and they're coming back, and we're taking out the kidney for somebody with metastatic disease. Bottom left is my oldest patient, Vera. She's 97. It's probably the 97-year-old to have a kidney removed. And then on the right is probably the largest single kidney partial that we've done. So my thoughts are that we need to do minimally invasive surgery at the highest possible level. So doing keyhole surgery as good as it's possible to do it. We need to expand the number of patients who have access to keyhole surgery. And by that I mean the people that you thought were a bit on the edge, that you didn't really want to do standard laparoscopy to, they can come to robotics, because we can do more difficult things. We can do more advanced tumours. We can do more dangerous things, because you get more experience. So you're suddenly bringing that cohort that might have been 50-50, you're making it 70-30. And the slightly odd one is that you can sometimes do things that no one's ever done in minimally invasive surgery, that no one's ever tried before. My colleague Raj Nair at Guy's has taken out a piece of somebody's cheek and refashioned it into part of the tube draining their kidney and done what's called a buccal mucosal graft. No one's ever done that laparoscopically. Raj has just done it. So this is Rachel this week, and Phoenix, which is a very apt name, is now 1. So the things that we can do to push these boundaries. This is a tumour that's going out of the kidney into the main vein. So it's probably like this tumour up here in the middle, just there. No one's trying that laparoscopically. You can do that robotically. Patient goes home day 2. How about this guy? This guy's got a BMI, body mass index, of 70. That's pretty big. He started bleeding from a kidney tumour. Nobody thought, didn't want to take him on. I mean, getting somebody like that through an anaesthetic, the robot doesn't get tired. It can lift up the skin. It's not like having an assistant. So we did him. This is him on the night of surgery, having had his kidney removed. It wasn't even that difficult, because we got the technology, we put it in, and it all worked nicely. Here's a guy with a massive tumour, the 12.5 centimetre tumour that we took out. So in urology, there's a whole range of things. And we've got a lymph node dissection after chemotherapy for testis cancer in the top left. This is kind of like overload of robotic urology. We've got a urethrolysis for a very stuck down fibrotic ureter in the bottom left. We've got a adrenalectomy for a tumour in the adrenal gland in the top right, and we've got a pyeloplasty for a poorly functioning, poorly draining kidney in the bottom right. And all of these things are done. So, of course, we're in a wonderful position if you have access to this, because once you can use it, you can do different things. So all of those operations are now standard for us to do robotically. Whereas 10 years ago, none of them were standard. So what about other things that we haven't considered? Well, this is one of my sort of things that I did for the first time this year, which is taking out lymph nodes of somebody's groin. We've docked the Da Vinci robot to somebody's thigh. You'll be pleased to know, in combination with a plastic surgeon who knew a lot more about the anatomy of the thigh than I did, who helped me put the ports in, but this is for a rare tumour that had spread to the groin. Why do that? It's a bit of hassle, it's only a cut in the groin. Well, that patient had a cut on the groin on the other side, and they stayed in hospital purely because of the complications of that wound, whereas this wound was fine. This is somebody with a stoma who could have robotic surgery to take out a kidney. This is a kidney transplant, top right. So that is putting in, not taking out, putting in a kidney with the robot. Colleagues at Guy's, Professor Nizam Mahmood, done a whole series of these. We've got oral cancer, so taking out a tonsil. And they're the two images on the bottom right there. So what about if you find two things? What about if you have a kidney tumour and you've got a problem with the gallbladder? Is that common? Well, people come with gallstones, they have a scan, they find a kidney tumour. It seems ridiculous to subject them to two operations. So my wife Sarah, slightly reluctantly, we've done this a couple of times now when we found gallstones that have alerted us to a kidney tumour. This is an interesting marital surgical issue, this, which is she sits on the robot and I have to do exactly what she says. Interesting. I have to drive the robot and she can't drive it at all. Also interesting. Theatre staff much amused by the dynamics, but it went really, really nicely. And there we are, and there is a gallbladder and a kidney tumour, because of course the patient's got cancer, they want the cancer out, but they came in because they got pain. So why not do both? So what is everyone else doing? Why do we need it? Well, in lung cancer, all of our lung cancer at Guy's is now done robotically. All of our removals of parts of the lung, lymph nodes, the thymus gland. We've started, the gynecologists are now doing malignant hysterectomy. We're starting to look at esophagectomy, so taking out the gullet and the stomach, and the lower GI surgeons starting to look at doing anterior resections. So here, this is what taking out a piece of cancerous tonsil looks like. So that's the breathing tube, the airway on the left there. Part of the tongue on the right. I'll stop there because I'm a bit out of my depth, but they do it very nicely. They don't need ports, it just goes straight in the mouth. And this is one of those ones where robotics has changed, in some patients, the whole thing. Some of these patients needed an 8-hour operation to split their face, to move their whole bones apart to get at what they need to get at with that open hand. And they're changing that to an overnight stay or day case surgery removal of a tumour. I mean, none of us have got anything like that sort of degree of change that they can offer these patients. And they've also done a tonsil and a lung in tandem. Asit Aurora, who I'm very grateful for the slides, and Tom Routledge. And this is Tom Routledge. I think he's done more thoracics than anybody in the UK. They've got the thoracics going a few years ago, and he's teaching people. He's done hundreds and hundreds of these cases now. I mean, this is high stakes. That's the heart jiggling around there. I'm not going to tell you about this anatomy because I don't understand it basically, but I come and watch him with awe as he staples off bits of lung, takes bits of lung out, and patients who would normally be in for a week go home the next day. And of course, we've got some colorectal stuff here, which is starting to do an anterior resection. So that's a tumour that is down in the lower part of the bowel, and you can see the surgeon is just literally sitting just alongside, like we do in all of these cases, and it's enabling you to get into a very deep, dark space otherwise with great precision, and they can staple across, and so the colorectal surgeons, I think, around the country are finally really now all desperate to get hold of this technology. So you do need to train. And you need to train with more than a game of operation, like you can see there. And you also need to train more than we did at a course in Belgium the other year, where we thought we'd see whether we could use the robot to make ourselves a cup of coffee. And Alex Motry does this trick a lot at all his events. He's just putting in some sugar. You can tell it's not England because they haven't got proper milk. Stir it and then hand it to whoever is opening the conference. I think it's his standard trick. But it just shows you, the dexterity of the robot. You can do what you need to do. So we train often with a dual console. As teaching hospitals, we're very keen that every robot we buy has got 2 seats. Why 2 seats? Because I want somebody on that seat. I made a pledge to the person who sent me on my fellowship that there'd always be someone on the other seat. And they get the same commentary, whether it's the medical student, the student nurse, the ODA who's come for the first time, or whether it's the chairman of the board, or MPs, or lords, the lot, everyone can come and sit, because it's by sitting and looking that you get it. And whether you're an advocate or somebody who can make it happen, or you're just one of our fellows who wants to learn, then that seat is important. It's key, because otherwise the surgeon never gets up, believe me. They never want to leave the seat. So you can do simulation, and there's some wonderful sort of modules that you can get with the intuitive system to train at and play, and we might finish a case early and have a practice, and whoever does the best score has to buy the drinks. It doesn't always work like that. But easier doesn't mean easy. As Prokar Das Gupta sort of has always said to us, our chair of robotics at Guy's, a fool with a tool is still a fool. I mean, you have to be able to use it, and you have to understand the limitations of the technology. So you do simulation, you observe cases, you have to learn to assist, because then you understand how the arms work. You do modular console training, which means that you don't just go for the whole operation. You might do just the middle quarter of it, and you do that 20 times, and then you do the second quarter, or whatever it is. But if you really want to learn, you give yourself a dedicated period of fellowship. And Australia is not a bad place to go, but you can go anywhere, and there's people who run these all around the world. And then you become a console surgeon. This is my friend Robin Weston. Him and I did a fellowship in Australia, and that's me helping him get going at Liverpool a few years ago. There I am on the console in Australia, and I'm hugely grateful to Tony Costello for allowing a POM to come over. And what do fellows look like? Well, I wanted to make this point. It's a really important point nowadays, is that there used to be all men, of course, in surgery, and these are our fellows over the last few years. I'm really proud of this, and they're from all around the world. The Australian contingent are in the top right, but we've had 4 female fellows in the last 2 years. And bottom right are the theatre team. So, what about the new systems? That's all about Intuitive. And Intuitive have run the whole park like a bully for 15 years. A nice bully with some brilliant kit. But if you're the only system and you're the only company, you don't have to perhaps drop the price or change the availability in the same way as if you're part of a competitive market. And that's not their fault. They're brilliant. Their system is fantastic. And no one has been able to come along with another system until about 2 years ago. And then these guys emerged. So this is the Versius system, and this is made by Cambridge Medical Robotics. Those of you who've played Game Boys and similar will notice the controllers are quite similar to a games console. Your head's not in anything. It's 3D glasses. And you sit in an open console. So one of the big criticisms of robotics with Intuitive has been that you were immersed. It's a positive and a negative. You were immersed. So if something happened outside your view, you couldn't see it. You couldn't see if the wrong instrument was being brought in or somebody was coming in the wrong direction. So they brought that back, and you now sit at a very open console. You can sit or you can stand, and you can see the hand controllers there. And a similar range of instruments. And this is how they are. They have 4 arms. The arms aren't all from one gantry. They're 4 separate arms. So if you only want to use 2, you could use 2 or 3 or 4 or 5. So you can be much more flexible. It's lightweight. It can travel between hospitals. So this is a British company, a startup company, now employing a lot of people outside Cambridge. And so these are the stats on it. The instruments are smaller. They're single carts, portable, same sort of 7 degrees of motion, 3D glasses, and it has some haptic feedback. What's that? Well, all of this great thing about the intuitive robot is that you can't actually tell if you're pressing something other than by watching it be displaced by your pressure. Whereas this has got a little bit of haptics in it as well. And that may be a key thing for the future. This is a cadaveric operation. So this is just in a laboratory, again, part of training with this, and that's probably why you'll see that it doesn't bleed. And this is just using this robot in order to really start doing the same operation I showed you right at the beginning. So this is a radical prostatectomy. Now, are they as good as Da Vinci? Well, this is Mark 1 for them. They've only been around. So are they going to be as good as the Mark 4 straight away? No, probably not, but they're much better than the earlier versions of Da Vinci. And they can do a lot of different procedures. You can suture, you can do the nerve sparing. So we think we're very keen to try and get one of these. Are they the only one? No. Well, a few other companies, and those in the sort of tech field will know. There's a few companies bubbling out there. So this is Medtronic. And Medtronic have got a robot by the name of Hugo. I think it's kind of friendly and approachable. Otherwise, everyone else is called theirs sort of Archimedes or Titan or Michelangelo. So they've decided to call theirs Hugo. Similar to CMR, it has an open console. You're not immersed. Similar to CMR, it has got 4 different little arms that come up to the robot. They've given me this. This is called apparently this is a teaser. So we can, if you watch closely, you'll see some actual views of it. But it's thanks to Medtronic. They're not CE marked yet in Europe, but they're coming out this year. They're going to have a showroom in London, and it's similar in terms of the instrumentation, small instruments, coloured pedals, open console, what looks like quite a cool ergonomic set of hand system, and lots of happy patients, of course. So Hugo RAS, robotic assisted surgery, there it is in the room. So I think that's going to be a big player. Why should they be a big player? Well, Medtronic are a company that have a number of other elements to them. They're not just a robot company like CMR. They've got stapling devices, energy devices, they've got ports, they do minimally invasive surgery. So they can bring all of that technology to their robotic platform. So suddenly it's integrated with all of the other kit that they have, which is pretty attractive. And how about these guys? Well, this has been on the cards for a while. This is Verb Johnson & Johnson. I've been there, Silicon Valley. They have a new robot now that is called Ottava, meaning an octave above. I think it's like surgery 4.0. 6 arms, 0 footprint. So 0 footprint means that it doesn't have anything that comes against the console, the patient. The arms come out of the table. It's amazing. So 6 arms, they all come out like a sort of great big sort of mantis out of the table. And you can use 3, 4, 5, 6, whatever you want. And they use, again, because it's Ethicon, they use all the Ethicon energy devices, all the Ethicon technology. These are massive companies. These companies are miles bigger than CMR, Medtronic and J&J. They're miles bigger than Da Vinci because they do minimally invasive surgery, laparoscopic surgery across the globe. And these guys have got machine learning linked to this. So they call it the connected ecosystem, but basically we think it's going to have metrics and you'll be able to learn and it will be able to show you the best person in the world who does an X operation, and we'll all be able to learn from that. So what have Intuitive done in the sort of competitive market? Well, last year or 2 years ago, they came out with this, which is a true single port robot. This is used clinically. There's none in the UK at the moment. This is one hole, and out of one hole come 4 instruments. And you can see already, this is the kind of kit that you would think would work. This isn't us trying to fudge single port surgery by crossing arms over. This is an ergonomically precise robot with a camera with dual eye vision. So you can get 3D vision with it, 3 different instruments. There's 60 odd in the world. It's very cool. If anyone's watching from my trust, yeah, I do want one because we could do some great stuff with this. Oral surgery, brilliant. Young people who want relatively scarless surgery, perfect. going up various different orifices of the body. So even transrectal surgery, you could do this beautifully. So it's going to have some uses. It's quite attractive. And that's not all. You can look at the transenteric robot, which you can look at the Avatira robot from Germany. There's orthopedic robots. All of these things are bubbling around. So onto the sort of future of it all. This is from Intuitive, and this is an animal model. And what they're generating at the bottom here is a graph, and the graph is tracking the movements of each of the hands. And so by tracking the movements, they can work out exactly what part of the operation we're looking at. If you do standard operation and you do standard moves, you can work out exactly what step you're on. Why is that important? Well, once you start knowing what step you're on, you can start predicting what step you're on, and you can start assisting on each individual step. So they've been tracking this, and they then have already come up with the next step, which is looking at an operation we do, which is radical prostatectomy. And in pink, is sort of light pink is the easy part, and the dark purple is the difficult part. And they can look at the different images and tell you exactly what stage of the robot procedure you're at, and quite quickly if you're any good at it. X in room 3 is struggling a bit. They've been on step 4 for 10 minutes longer than they should be. Ben, I think you should go through there. I can see that happening pretty quickly. Y is going to finish early. Let's move the case from theatre 7 to theatre 3 because Y is going to finish early. Straight again. You know, these things are going to help. And of course, the next step is, can we get the robot to actually do some of the operation? So what about really cool things that we can use to actually help us do some of the robotic surgery, other than we've seen the ultrasound, we've seen the dye? Well, this is a startup from King's College London called Innocyte, and Ethicon have got a similar one called Visible Patient, and I use this a lot. So I get a scan on our PACS system, I send them the link to our scan on the system, and they generate for me, not a printed model, not a 3D printed model, but something on my iPad, something that I can sit down and use and twist around and see for a kidney tumour. How deep does it go? How many blood vessels are there? Is that useful? Well, it can make all the difference. This is a tumour of the kidney, left kidney, upper pole tumour, quite a big tumour. Perhaps don't start with this one if you're having a go at this sort of thing. And I'm looking at the scan and I could see what I thought were 3 branches of the artery. But I'm looking at the model, and the model can see another branch, which I haven't been able to pick up, and nor is the radiologist. So the model's suddenly telling you there's more to this than meets the eye. It has predicted a blood vessel that is essentially only visible by computer enhancement. And then when we're doing the operation, I can actually go and one of the first steps, find that blood vessel, clip that blood vessel, release that, and there we are. I found him. So suddenly, I'm not looking at the scan on the monitor anymore. I'm looking at the model on the iPad because it's more accurate and it helps me more. And then this is Proximy. So Proximy is another startup company, and it's a telementoring company. So in order to learn, you have to be able to speak perhaps to an expert. You want to be able to interact. You want to be able to ring up somebody who's done 100 of something and say, I've got a tricky one. Well, this lets you do it. So this is founded by Nadine Hachacharam, who is our head of innovation at Guy's and Thomas's, and we use this all the time. And in COVID, small allusion to COVID, I taught medical students, I taught registrars, we taught fellows, we did courses, and we beamed this out all around the world. And this... Hello, Sir Ben Challacombe here from Guy's. Very grateful today we have the Proximy team in our theatre helping us with some telementoring. And here we have next door on Vinci Xi, and we have our fellows on there. Cara McDermott, she's just thinning down the dorsal vein complex. Yeah, that's good, Cara. Just go and stay in the wispy stuff there. Try to see if you can just drop it down. Can you see my finger on the screen? Just in that bit there. And if you lift that off, that'll make, stay in the wispy stuff. Really good. That's nice. And then we're ready for the dorsal vein in just a second. Well done. So I can watch an operation. I'm in the next door theatre, but I don't have to be. I could be in the office. I could be carrying on doing some other things with patient care because that trainee is extremely good, and she only needed me perhaps for 5 minutes of the operation. And so I can watch, and I can put my hand on the screen, and I can guide, and I can draw a line, and I can show hand movements of how to do things. And if my colleague in Canterbury rings me up and says, Ben, I've got this funny variant of the anatomy here, could you have a look? I can do it, and I can guide them. Of course, there's some medical, legal, of course, there's some ethics involved, but this technology is absolutely ready for rollout now. It's been used in 6,000 cases around the world, and it's simple enough that people have used it in Gaza, people have used it in Africa. Nadine's used it on members of her own family to do a difficult procedure.
You should see aortic pulsation. You see aorta right around here? Yeah. So your incision is going to be something like this, okay?
So that was in COVID. We wanted to do some really challenging robotic surgery on men who've had testis cancer and have lymph nodes left. And we had planned to go to America and we couldn't do it. So we got Proximie on the case. They rang up Jim Porter, who's a friend of mine in Seattle. And this is Archie Fernando, who's a wonderful surgeon with our group. And she does a lot of these retroperitoneal lymph node dissections. And we can do the operation, but we just couldn't quite do it the way that he did it, which was a really elegant way. So, I mean, safely, we had a fallback. But over the link, I think he had to get up at 4 in the morning in Seattle, several cups of coffee, but he taught us how to do it. And that's the patient's scars. And they went home after day 2, not day 10. You know, it's a game changer. So enough about eulogizing about why robotics is so good. Let's talk about why robotics might not be so good as we think, or what are the downsides. Well, of course, it costs a lot. If you want to buy a dual console, it's 1.8 million. That's a lot of cash. You haven't got them everywhere. We use them in urology. We've got 110, but there's plenty of places in the UK that haven't got access to one in their local hospital. And of course, if you look into the developing world, no one's got one. It may not be their top priority for a lot of surgical things, but certain countries don't have access. Training, you can't just unwrap it and have a go. There have been disasters with people just having a go. You've got to train, you've got to be dedicated. And for people who are already busy and seeing a lot of patients, training when you're a consultant is not easy. And it doesn't have any haptics. Why is that important? Well, here's something which shouldn't happen. So this is a partial nephrectomy, and we're trying to take out a kidney tumor. This is someone I trained, not me, but it could have been. I think I've done it. And whilst desperately trying to make sure that we've got everything settled, I'm really grateful for him for sending it through, actually. Stuff comes over the top. And what has happened there? We've burst the kidney tumor. Disaster. Why didn't you know? Because you can't feel it. Your hand's against something and you can't anticipate the pressure sometimes that you put the tissues under. So you can use the instruments incorrectly. You can burn holes in veins if you don't know how to do it. But nobody sues BMW when you go 120 miles an hour on the motorway. That's your fault, yeah? So you've got to learn how to use the kit. So in the old days, people sued Intuitive, but they don't really now because most of it's due to poor use. But is it reliable? Absolutely, it's reliable. And is it slow? No, we can do things much quicker than we used to. I can take out a kidney in an hour in an easy case. I can do 3 cases a day or 4 cases a day, where laparoscopically and open we did 2. So it's not slower. It's slower to start with, but it's not slower. And the theatre can be made with great teams and great assistants to be much more efficient. So robotic surgery is definitely rewarding and enjoyable. It can be pretty stressful when the clamps are on and you've got 20 minutes to close a rather large hole in the kidney and the stress is against you. As I say to my kids, if you want to do medicine, I'm afraid the alarm clock always starts at least with a 6 and it could start with a 5, but that's the same for many jobs, I think. But there's great opportunity for collaboration and teamwork, technical and non-technical skills. So this is a guy I did an operation on. He's raised the most amount of money in the UK ever for Movember. So huge legacy because I did his prostate. So fantastic that that's his 5-year anniversary of being clear. This is us raising money for the Urology Foundation, who sponsor so many courses for people and visits for people to learn about robotic surgery. Stephen Fry, who was brave enough to come and see me. He'll want to show you a picture of him looking a bit more svelte than that, but he's been a great advocate and supporter of us. And that's a rare one of me actually sitting on the console. So the most dangerous phrase in language is "we've always done it this way." I hate that phrase. That's from Rear Admiral Grace Hopper, who was an intelligence officer in the American Navy at the end of the war. We never say we've always done it this way, you know, and we need people to take these things on. So what are we going to do in the future? I think we've got to have a national procurement policy. We can't have every hospital doing its own deals with Intuitive. We have to be able to say that the country wants this technology. If we buy 100, you're going to sell it to us at 2/3 of the price. You know, at the moment, it's all over the place. And therefore, we get equitable access. You know, just because you live in Dundee or North Wales shouldn't mean that you should have open surgery because there's nothing available. That's tricky because you don't want to stick a robot in a remote centre where nobody can be trained. But we have to have good access for all patients of all specialties. We therefore need validated training schemes. We have one in urology, but we've been doing it a while. But you know, there needs to be a validated scheme for colorectal, for transoral, for thoracics. And therefore, the trainees need to be exposed throughout their training. Training a consultant is really difficult. Training a registrar in year 1, and my view is if you're good enough, you're old enough. You know, that's how we've got to do it. And we've got to work with industry to help with the imaging, with the sensors, with the energy sources. And laparoscopy, perhaps, for me, 5 years' time, certainly 10 years' time, you're only doing that for relatively low and intermediate complexity things. You're really not doing laparoscopy for anything that involves a degree of delicacy, dissection, reconstruction, things that require stitching. So the future of robotics, ladies and gentlemen, I think really the future is robotics. So thank everybody for staying in, staying tuned. Thank you for your attention. I would like, of course, to thank Professor Kirby, the president of the RSM, his predecessor, Professor Sir Simon Wesley, FRS, recently for the original invitation, because they invited me to do this last year, and of course it couldn't happen. Dennis Cope and the Urology Foundation, who sponsored my fellowship. The Thompson family, who've been great benefactors to TUF and allowed a lot of other people to be trained. All of the people in industry who've sent me some images and some videos. Prokar Das Gupta, who took a punt on me and said, hey, do you fancy doing some research in robotics? And urology, nursing, management, surgical colleagues at Guy's and St Thomas's and other hospitals who've allowed me to develop it along the way. Sarah, my wife, all my boys, my mum and dad, and of course, most importantly, all the patients who've trusted me. Thank you very much.
Great. Well done, Ben. Very good, very good. Stay there for a minute. I'm just going to pin this medal on you, if I can find it. It's somewhere in here. Yes, here it is. So this is the Stevens medal, which I'm going to put on Ben now.
Amazing.
If I can get it around the right way around. Just stay there. And I'll see if I can do this. Very distinguished medal, given to a very distinguished urologist. Okay, just go and sit there, Ben. So thank you so much, Ben. Thank you so much, the Stevens family. I'm looking at them now, all lined up. Thank you for Ben's family, who are here supporting him, and thank you for the 600 or so people that registered for this conference today, this webinar. It's really interesting that we can get this information out to so many people using this Zoom technology. We had about 11 questions in so far. If you want to send some more in, please do that. And I'll just come over here and we'll start off. Ben, let's talk a little bit about the financial aspects, because you're saying it's £1.8 million to buy a machine, and compared with open surgery, where you just need a scalpel and a pair of forceps and so on. I mean, what's the price differential, robotic versus open surgery?
Well, as you know, we would all appreciate, robotic surgery is more expensive. It's more expensive than open surgery by quite a lot, and it's more expensive than laparoscopy. Even in a very slick system, it's still more expensive than laparoscopic surgery, although you don't need some of the energy sources that you would use. But what I would say, Roger, is that it's quite difficult to measure things that you don't see. And people say, how often have you converted to open surgery? Well, not often. With prostates, we haven't really converted for 10 years. So that's a lot of money if somebody goes back for bleeding or goes back to theatre or goes to ITU or needs a transfusion. We're not seeing those. So actually, in terms of length of stay and hospital stay and complications, some of the money you spend on the outlay, of course, is brought back by the fact that the surgery generally has better results in most places.
Okay, there's a question here from Dr. Nahiti. Says, how long do you think it'll be before you'll be able to have full surgery with artificial intelligence mapping, informing the surgeon of the ideal operation that he should be doing? I mean, do you think, I mean, and even one step before that, a robot actually should be able to do the whole operation and you can go off and play golf?
Well, yeah, I'm not very good at golf, though. I'm probably better off not. But I think at least 10 years. I mean, realistically. I mean, having been to some of these centres and been to their labs and seen what they're doing by modelling the movements, I think that programming is very complex, because we're talking about soft tissues, deformable tissues, as in they change their shape as you go through the operation. The kidney changes shape as you move it around, as you chop a piece out of it. So you've got to actually have an adaptive algorithm there that actually looks at how it's deformed by your instruments. What is more likely is that we'll have a stop, red zone, you're going near the renal vein, you're too close. Right. So constraints within surgery. So that will be allowing you to do things, but if you do something ridiculous, it'll stop you. Right. So I think that'll come first, and then it'll start doing simple steps, but I think 10 years.
Might be the same when you drive your car. Automatically stop.
Well, exactly.
Well, Christopher Peters says, the use of robotics is spreading faster than the evidence for its benefits. If we accept that the future is robotics, how do we control its expansion and make sure that there's not a wild west of surgeons trying new things with inadequate training?
Well, it's a good point. I mean, there have been disasters when people have, surgeons aren't always the most insightful about thinking that they might need to spend a few extra hours in the lab, and perhaps, the older surgeons, of course, have less time and actually need more time, because I've taught people from 30 to 55, and who do you think learns this more quickly? It's the 30-year-olds every single time. So I think that there won't be a Wild West, because we're going to bring in these structured training programs, and we're going to have national mentors, and perhaps a national sort of robotics committee is perhaps what is needed as we go into general surgery and gynae in a more major way.
Yeah, Neil Smart says, brilliant lecture, Ben. Could you touch on the change seen in the USA with regard to the use of robotics there? Because gynae is hugely popular for the use of robotics in the US, isn't it? Yeah, I mean, I would. Why didn't our colorectal surgeons get into this? I think because they were always a bit better and a bit earlier in their use of laparoscopic surgery, so they didn't perceive that they needed it. And urologists had always been struggling a bit at laparoscopic radical prostatectomy, and the robot came and it was very good at that. And in the States, yeah, I mean, it's a private healthcare system, and people want the robot to operate on them. I mean, and I'm afraid it will become a little bit like that in the UK. It won't be the first couple of colorectal robots or gynae robots. It'll be the next step when half the places have got gynae robots and half haven't, and suddenly people will ask to be referred, and I think patients will vote with their feet to a certain extent. Well, Josephine Silas says, can you go from open surgery to robotics bypassing traditional laparoscopic surgery? And I guess there's a corollary to that, is that if everybody's trained robotically and then the robot suddenly conks out, or you have a power cut, or there's a problem with the patient, I mean, will the people be skilled enough at open surgery to be able to just open the patient up and sort it that way? Well,
as you would imagine, it's a question that we are asked quite a lot. It's the sort of question you ask trainees at their consultant interview. Interestingly, it's easier to train somebody who's going from open to robotics directly than it is somebody who's gone from laparoscopy to robotics. Because in open, you're used to using your hands. And in robotics, you use your hands and your wrists. In laparoscopy, you're used to relatively straight movements. And so you have to sort of get out of them the process of where they kind of move laterally and up and down in very long, wielding, exposing way. So I would rather teach somebody who actually has done no laparoscopy. Mm-hmm. But most like yourself, you went from open surgery straight to robotics. You never did laparoscopic to any huge extent, and you took to it within, you're up and running in less than 6 months. So.
How many cases do you think that somebody needs to do before they get proficient? I mean, there's a question, I can't find it now, about esophagectomy, saying that robotic esophagectomy, in the first few cases, maybe even 10s and 20 cases, the leak rate, which is devastating complication, of course, from esophageal surgery, is higher with people in the learning curve. Any thoughts about learning curves?
Yes, I mean, it's, again, something that, as someone who's training people week in, week out, you're very interested in how quickly they learn. I mean, there's no doubt there are some people who just, you can spend your whole life, they're never going to be very good. And it's, it doesn't matter. I could go and play golf every single day. I will still not be very good at golf, I don't think. Luckily, you can get better at, in surgery by other ways other than just physically doing it, and you watch stuff and you go to visit people and you do courses. But ultimately, there are some people who are not as easy to train as other people. I think the learning curve is, you can't give a number. You can say that people probably benefit from a dedicated year, and if at the end of that year you can do just simple cases, that's fine. But if you can do complicated cases, that's better. So I would advocate anybody who does this to try and do a dedicated period of fellowship.
Yeah, just like you did in Australia. Well, we could continue this conversation for an hour or so, but some folk in the audience here are looking a bit hungry. I'm certainly getting hungry. So I'd like to say thank you to Ben. Thank you to the Stevens family. Thank you to the RSM for allowing us back in the building. Or maybe we should even thank the government for allowing us back in the building. Just a final word to say the Royal Society of Medicine has struggled through the pandemic. We've done our best in producing webinars, and it's fun that we've been able to get to so many people just around the whole world, really, by webinar. But we are now back in the building, so I'd invite you to come in and join us here. We'd love to see you. If you're not a member of the RSM, you can apply to be a member of the RSM. We'd love to have you join our membership, our fellowship and for the future, if you're feeling generous and you want to support the RSM to help us continue our education and innovation program, we would definitely accept your generosity. So thank you, everybody, and good night from the Royal Society of Medicine.